start our session now in discussions. And we're going to have, how we're going to arrange it, we're going to have 3 presentations, and then we'll break for a discussion. Therefore, I would like to request you to take note. If you have any notes, any comments that you want to make, just put them down, and then after the 3rd presentation, we'll invite you to make your comments regarding the presentation. I want to now invite Dr. Mohamed Toure from TACAIDS, from UNAIDS, to make the first presentation. Karibu sana.
Good afternoon, everybody. Thanks to the TACAIDS team for allowing us to make this presentation. This presentation is very important in that it's going to help us set the scene. It's going to help us set the scene against which other presentations and discussions will be made. This presentation is so important because its provisions constitute the most comprehensive data set on the HIV epidemic as at 30th December 2021. It is comprehensive because it's the countries themselves that reviewed their data and submitted their data to UNAIDS, who, according to the General Assembly, is mandated to analyze these data sets every year through the Global AIDS monitoring process. I'll start by discussing the 3 very important indicators here that we are all so familiar with. But before I proceed, I wish to let you know that based on the outcomes of the analysis of the 2021 data, the report from which this presentation was extracted was dubbed as in danger. It was dubbed as in danger, as you can see from the first slide here, because the key indicator sets that countries and the world would need to achieve in terms of the targets by 2025, which will put us on track to achieve our 2030 targets, are shaky. Which means, as at 2021, we are not really on track to achieve those targets by 2025. And as a result of that, our achievement of the 2030 targets to end AIDS threat is very much threatened. So, the global AIDS situation is characterized by uncertainties. And as we can see here, people living with HIV keeps rising, but there's no problem about that. If there are new infections and people continue to stay alive because of treatment efficacies, then we accept the portfolio of people living with HIV to continue rising. And as at December 2021, the total number of people living with HIV globally was 38.4. And new infections was 1.5 million. and deaths due to AIDS was 650. But let's pick on the most critical indicator here. The indicator really stand out to threaten our ability to achieve the 2025 targets, which is new HIV infections. Let's have a look at the details in brief. As you can see, the number of new HIV infections, of course, keeps decreasing. But what is the problem here? The problem is that we are not on track to hit the magic targets there. Because if we're supposed to hit that target by 2025 before we can be on track to achieve the 2030 targets. So that is the main threat here. And that is the endangered situation that the AIDS in. So, of course, there has been a slowdown, but new HIV infections fell by only 32% since 2010, which is far short of the 83% decline that we need to achieve the 2025 targets, which is 370,000. Just compare where we are, 1.5 million, and in 4 years' time, we're supposed to reduce that to 370,000 new infections. It's a tall order. We need to do a lot. And in Eastern Europe and Central Asia, including the Middle East and North Africa, we've seen an alarmingly high increase in new infections. Some of these countries, like Eastern Europe, the Middle East, were once seen to be very safe zone, but of late we've seen new infections rising in these countries. And of course, adolescent girls and young women accounted for almost 4 in 5 of new infections among young people in sub-Saharan Africa. And also we are seeing new infections rising. So every day we are witnessing about 4,000 new infections per day. And of that, 58% is in sub-Saharan Africa. Of that 4,000, 430 are among children under the age of 15, and 3,600 are among adults, 15 years and above. So this is, in summary, where we stand as of December 2021 with the start globally of new infections. Let's have a look at this related deaths. We are doing much more better in stopping people from dying than stopping people from acquiring new infections. It's really huge. But the question we are asking ourselves is, are we still on track? At 650,000, and also our region, ESA, Eastern Southern Africa, will bear the greatest brunt of it. So although on the decline, the current trend will lead to 460,000 AIDS-related death calls in 2025. And that figure, for that figure, will be 25% more than the 2025 targets of 250,000. So our region continues to be the epicenter of the epidemic. Let's have a look at children. Children living with HIV is 1.7 million, and new infections is 160,000, and deaths due to AIDS is 98,000. We needed to single them out, so we have on children. So looking further at new infections, we want to see the proportion of the 1.5 million new infections, how that is allocated or distributed among different population groups. But one thing that is very concerning in this chart here is the rise of new population group that is really bearing the brunt of new infections. That is clients of sex workers and clients of sex workers and sex partners of key populations. It's 25%. Compare that to the others, to our traditional key population groups. And these clients are from the general population. Their husbands, their teachers, their young people, and new infections are rising within this population group. It is very, very concerning. We need to have our interventions really influenced by these figures. And let's further look at the distributions in sub-Saharan Africa. The trend still is the same. Clients of sex workers, we're seeing quite a huge contribution from them to, in new infections. %3 here. Let's take a look at how the dispersion is regionally through geography. You see that adults and children estimated to be living with HIV are in 20.6 million out of the 38.4 million. For new infections, here, estimated number of adults and children newly infected. This one was total living with HIV, and for new infections, 670,000 out of the 1.5 million came from sub-Saharan Africa. And estimated adults and child deaths from AIDS, we still bearing the brunt of that. Looking again at children estimated to be living with HIV, ESSA bears the brunt of 1.1 million out of the 1.7 million. New infections, 78,000 in ESSA out of 160,000. Deaths in children, 45,000 out of 98,000. So looking at it, summarizing, we are within this region really taking a huge portfolio of about 50% for the three indicators. That's illustrated here by the summary. Let's have a look at a few other critical indicators at the global level again. 95 indicator set, even at the global level, we are doing very well on that. The world is doing very well on that. 85% of people living with HIV knew their HIV status, and 88% of those who knew their HIV status are on treatment, and then 92% of those on treatment are suppressed. But it's important to note that women exceeds men in these figures, but the analysis further indicate that the reason why most countries have not been able to achieve or are not on track to achieve this target is because of discrepancies in wealth. It's because of inequality. That is what the analysis showed. On the 10-10-10 targets, having 10%, less than 10% of countries with punitive laws that impede access to health services, having less than 10% of people living with HIV and key populations free from stigma and discrimination, and having less than 10% of women and girls, people living with HIV and key populations free from gender inequality and all forms of gender-based violence. One country reported meeting the targets for women making their own decisions, and no country reported achieving the near absence of discriminatory attitude towards people living with HIV. On coverage and use of combination prevention among gay men and other men who have sex with men, the coverage was low on that. And over 1.6 million people worldwide were receiving at least once, increased twofold from 820,000 to 1.6 million in 2021. And this happened notwithstanding the MMC. We saw only Kenya really meeting its target. But of course, followed by that closely, Tanzania and Ethiopia are on track also to meet their target. And 82% of pregnant women living with HIV received ART, and there is a stagnation, particularly within Western Central Africa, where coverage levels of 60% are below the 100% required for 2025. On community-led service delivery, there wasn't much information. So that really shows that, which suggests that considerable work is needed to achieve the 80% target that is needed for service delivery, prevention services for key populations. Coming to the resources, the United States government still remain as the most reliable partner in terms of providing funds towards the global AIDS response. Bilateral assistance from other countries had decreased markedly by 81%, particularly from the European Union. Domestic resources, decades, and allocations from the Global Fund have really come into cushion the effects for many countries during COVID-19 period. So, what is the direction? What are we planning to do to address the issues that still persist? To address the challenges that we're still confronted with, particularly in the area of new infections. UN's partnership with countries and other development partners have come up with initiatives, with 3 big initiatives of late. And the first one is that of the Global Prevention Coalition. The Global Prevention Coalition has a roadmap which encouraged to pursue as a way of addressing new infections. You have the 10 priority actions out there. The roadmap emphasizes the need to end inequalities. It stresses vital roles of community-led action to implement programs at scale. And it calls for discontinuing investment in interventions that are not smart, that are not providing great effect in terms of reducing new infections. And it highlights the importance of sound management, accountability, processes of multisectoral prevention responses. The other initiative is that of the Global Coalition to End AIDS in Children. Of course, the UN and other development partners are in serious engagement with government to address this issue. And the third initiative is that the Education Plus initiative, which is about really improving adolescents' education, health, and well-being agenda to ensure that overall we can reduce new infections among adolescents and young people. This, in brief, is a summary of the global AIDS situation. But as at 2021, every year countries will submit their data and thorough analysis will be done. We're hoping that for 2022, things will get better. Thank you so much. That's the end of my presentation.
Thank you so much. Can you just give him another round of applause? This has been, you have indeed helped to set us in motion. And we will now invite, I just want to comment as your moderator that as we try to save us time, it is very important that we don't eat into the time that we have beyond. Therefore, I did not mention at the beginning, but all the presentations are going to be done in 15 minutes. So as a presenter, you have 15 minutes so that we have time. Just concentrate on the most important information that you want to give us, and then we will continue with the discussion later on. So now we will welcome Farida Ali from the Regional Secretariat Lindi. She will make a presentation on Lindi region HIV response towards attaining the 95 targets. Karibu Farida. And I will try to guide you, so please turn your head once in a while on my side. I'll try to alert you when you are 5 minutes to complete and when the time is up. I'll appreciate if you can do that.
Thank you. Good afternoon, everyone. My name is Farida, a medical doctor, also MSc in epidemiology and biostatistics. I'm going to present the Lindi progress towards attaining 95 HIV targets. Before we start with the HIV matters, let me take you through the regional profile, because I think most of you are new in this region. This is the map of Lindi region, which is among the 31 regions in Tanzania. It has 6 councils, namely Kilwa, Lindi Municipal, Mtama, Ruangwa, and Iliwale district councils. We are bordered by some of the regions and also the ocean. As on the northern, we are bordered by Pwani region. The ocean we have Morogoro. On the southern part is Mtwara, and on the eastern part is the Indian Ocean. The Lindi population is of 1,194,028 people. And this is one of the regions with accounts to about 49% of the population. The main activities in Lindi is fishing, agriculture, especially for the cashew nuts. And we have the mining activities, which is mostly upcoming, especially in Ruangwa and in Nachingwea. Also, we have the upcoming local natural gas, which we are anxiously waiting to receive. In total, we have 272 health facilities. Amongst them, we have 10 hospitals, 26 centers, and the rest are dispensaries. Among these health facilities, 130 facilities offers care and have care treatment centers, which is about 48% of all health facilities. 48% of health facilities offers PMTCT option B plus services, and only 60% of the facilities offers HIV testing services. I think I will skip because this was well captured by the previous presenter. Now, going to Lindi, I thought it is not very pleasing me going to Lindi directly without getting the picture of the national. As you can see, in the nation, we have more than 1.7 million people estimated to be living with HIV. And this is as of 2021 data from the National AIDS Control Program. The national prevalence was 4.8% according to the HIV Impact Survey of 2016-2017. And people currently on ART were more than 1.5 million, and new HIV infections were around 200,000. Now coming to Lindi, the estimated number of 3, according to 2021 data of National AIDS Control Program. The prevalence was 0% as of 2016-2017 Tanzania HIV Impact Survey. And we had 25,146 people who were currently on care, who were living care were currently on care by 2021. And the new infection as shown, with 33% being youth and 73% of youth were female. Coming now to the progress towards attaining 95 targets through the care and treatment services. Out of 299 clients who received the care in 2021, 99% were receiving ART. 26, which is about 0.1%, were clinically malnourished, and 85.5% of these clients were screened for TB. And 0.3% of all clients who were on care were receiving TB treatment. Out of 25,146 clients who received the ART in 2021, 96% aged 15 years and above. And if we go further, less than 15, those who aged less than 15 accounted to about 4%, and the youth, meaning 15 to 24 years, were 6%. Majority of these clients were women and girls, and 2.5% of the clients were on second-line ART. Only one person was on third-line ART regimen in 2021. And 1.9% were dispensed with 6 months ART. Now let's see the trend of second-line ART in the region. The trend has been decreasing since 2018 to 2021, though the decrease is not very huge. But we see from 2018, those who were in second line were 4%. We had 4% of the clients, and the trend has been decreasing to 2.5% in 2021. Now let's get the picture of HIV-related death in the region in 2020. Actually, this is the trend from 2018 to 2021. We can see that the death, the proportion, we can say it is steady. There is no huge decrease. In 2018, it was 20.4%, then 26.2%, 25.1% in 2020, and then it remained the same, 25.1% in 2021. Now coming to the PMTCT services, where we concentrated on the DBS coverage and the HIV positivity rate among HIV-exposed infants at the age of 2 months. So as we can see, the DBS coverage, there is slight increase. We came from 70% in 2018, but in 2019, a bit of decrease. Then we increased it to 73% in 2020, and then 71%. I think we have a lot to do in this area to ensure that we are stepping up. And the positivity rate has been decreasing. It was 5% in 2018, but in 2021, it has gone to 0.5%. Now, towards attaining the 95 target, I think the global data were presented. The regional data, we compared with the national level. For the first 95, we are on 92%, meaning that people living with HIV who knows their HIV status, we have 92%. So we are nearly meeting the target of 95%. And for the second target, we are on 98%. So at least we have gone beyond the 95%. And the third 95, we have 96% of the clients are virally suppressed. But it is good to appreciate that even if the viral load suppression has been overall is 96%, but we have discrepancies according to the age bands. As we can see, the adolescents are still lagging behind. And even when we consider adolescents 10 to 19 years, they are lagging behind. So this is also the area that needs a lot of improvement. And one of the things that can help and we have been going on discussing is about the improving on the youth-friendly services, which is currently offered in only 10 health facilities of the Lindi region, which are the hospitals. But this one should go even down to the lower level facilities. As a region, we have identified some of the gaps towards our progress. The first gap is first 95 targets is not yet achieved. We have 92%. And even in this 95%, back in our mind, we know that the estimated number of people living with HIV is 28,753. So, but the people who were on care were 25,299. So we have not reached the reaching all people who are living in HIV, are living with HIV. But when we are analyzing this 95%, it means that it could be even lower because we have not reached the target of people who are living with HIV to be all getting care and treatment services. Another gap is shortage of healthcare providers in these care and treatment centers. I think all of you can appreciate it, that in Lindi region, we have only 40% of the minimum requirement of the healthcare providers, not even the maximum, 40% of the minimum requirement of healthcare providers. So they have a tedious work to do, to the extent that even working hard to ensure that the HIV services are maximally implemented to capture the patients, to provide the critical care to these patients, and to see that we are attaining our targets is a challenge. But we also thank the implementing partners. Partly they help us, but still the condition is not promising. Okay, also no viral load testing laboratory at the regional level. So all viral load tests are being done at the zonal health laboratory, which is in Mtwara. So this one makes difficulty, especially in turnaround time of these results. So this delays some of the decisions. For example, you have a patient who is prescribed with multi-month dispensing, and you have taken the viral load testing. Then when the turnaround time is very prolonged, sometimes these patients have deteriorated and needs to be shifted maybe to the monthly. It's not stable. So this one is a very huge challenge. We have 32 health facilities are not supported by the implementing partners. As I said earlier, that 98% of the 98 health facilities are supported by our implementing partners. But the health facilities that offer care and treatment services. So this gap is very huge because even health facilities, their poor performance will drag us back. As a region, we have set the way forward and we are working on them to ensure that we attain the target and we even go beyond it. The first one is intensified self-testing, providing the facilities for self-HIV testing and in all regions. So we hope that this one can help us. The second way forward is implementing partners should consider recruitment of short-time workforce under contract basis at the health facilities. Not only the data clerks, but also the other professionals in the care and treatment centers. Also, the Ministry of Health has been collaborating with the implementing partners for establishment of viral load testing services in the region so as to eliminate the problems that we are facing regarding the viral load testing. And the last one is extension of the implementing partners support to 32 healthcare workers, to 32 health facilities that are lacking their support. So communication is continuing, some discussions and negotiations on how they can extend these services to the remaining health facilities. So thank you for your participation and listening.
Thank you so much, Farida, for a very good presentation, a very good follow-up and follow-on to the opening of the presentations from UNAIDS. We have seen that we have the same trend at the regional level. We have unequal outcomes on the side of adolescents, even where Lindi is doing very well, especially in testing, HIV testing, and also on ARV. So it's an area which we really need to look at as we continue discussing and come up with strategies and propositions on how best we can have differentiated approaches that are going to have impact on the young people, the future of our country. I would like now to invite Dr. Wena Maukola from NSCP. He is the strategic communication head of unit head at UNAIDS, to give us a presentation on overview of the National HIV Care and Treatment Program. Karibu Dr. Wena. You have 15 minutes, sir.
Habari za mchana. Thank you for giving me an opportunity to shed light on what has been transpiring on HIV implementation. And luckily, most of the stuff has been covered by my two colleagues, so there will be petitions. So these are the outline of my presentation. I'll talk about the background, ART, management of comorbidities, a bit on health information system, and the pragmatic gaps in implementation. So we all know our program started way back in 2004, and currently we have 1.7 million estimated PHIV and 1.5 on ART by September 2022. This is a famous graph, but the message here is, as my other colleagues said, we are struggling with first 95 and a bit on the third 95, and especially on children, adolescents, and youth. So the blue ones are the overall, but the colored ones corresponds to different ages. So the problem still is on the first 95 and third 95. Again, on 95, this is by sex, and males are doing very bad, especially on the first 95. So I think this has been what has been said by my other colleagues. We are also struggling with male adults. Okay, so the aim of showing this drawing on my left here is just to remind us the different ARV drugs we have. We have different groups, like we have the fusion inhibitors, those which prevent the virus from attacking the target cell. We also have the reverse transcriptase inhibitors, NNRTIs and NRTIs to prevent the conversion of RNA to DNA. We also have integrase inhibitors, which prevent the integration of the viral DNA into our cells. And the other one is protease inhibitors, which prevent more virion from being produced. So, sorry. So the message here is currently we have optimized the ARVs, and for adults we are having DTG regimen, and we have come from NNRTIs based regimens, and for children we also advocate DTG based, and we came from PI based, lopinavir boosted. So in connection to the other slide, we have ART optimized for us to adopt potent drugs. But you agree with me, even if we have potent drugs, HIV drug resistance is one of the things which can render those drugs not working properly. So I just want to share with you the result of acquired drug resistance survey we did with colleagues from MOHAS, and that was in 2020, and we involved all the 26 regions in Tanzania mainland, and we involved those who were on ART at least for 9 months. So in summary, this is what we did, recruited close to 2,000 participants, and we did HIV viral load, and we found up to 137 had higher viremia. And among those, we went further doing HIV drug resistance testing. So these are the results we got from 137 participants who had high viremia. And the graph shows close to 72%. That was the mutation we got, or the overall. But for integrase inhibitors, we got up to 5.8%. And this was in 2020, and DTG was there for a short time, but we already got close to 6% resistance. But for NNRTIs and NRTIs, as usual, from other literatures, we had up to more than 50% resistance. And for PIs, it was 8. So this is this echoes that drugs which have been with us for a short time, like DTG, have also started having mutations. A bit on management of comorbidities. One of the things we're doing for communicable disease is TB. And one of the interventions we are banking on is TB preventive therapy. And this graph shows the performance of our regions by September 2022. And you can see some regions are very behind, close to less than 50% performance. And this is the total number of PHIV who have received IPT since the beginning of IPT versus those who are on ART. So Njombe, Ruvuma, and Rukwa were behind. And this is by September 2022. But on the other thing regarding non-communicable diseases, you will agree with me, we've done very little, and this is the result of patient level analysis. We always do data analysis for patient level using CTC3 data, and you will agree with me, the numbers are very few, and I doubt if this is what is the real picture, but this is captured in CTC2 over the years. But if you look at it, at least over the years, the diagnosis of non-communicable disease is going up a bit. Regarding HIV, as management information system updates, on recording and reporting tools, I think this is familiar to you. I just wanted to remind everybody we have recording and reporting tools, and these are the tools we have. But on HMYS, I just want to share with you the progress we have, and especially on making our data digital. And from this slide, you see the updates on what we have done so far with regards to trying to make our data digital. So one thing on CTC2, as you all know, that this is an electronic medical record for our patients, and it's all over, and up to 95% of our patients is electronic. So within the electronic database, we want to, actually we have started having these extensions. So we want to have a module on HIV testing. We have a module on pharmacy module. Pharmacy module captures details regarding drugs. We have a module on HIV resistance testing surveillance. So we are doing surveillance in some of the facilities to see the timing of the infection. So that will be built within the CTC2 database. We also have a module for COVID-19 vaccination. And we also have biometric module. And for biometric, we have started in 2 regions, in Pwani and Morogoro. We have started registering clients in 6 as facilities, and we use both demographic and biometric information. So, and we want to expand it to Dar es Salaam region December. So another one, and which is actually very important in trying to improve our data between CTC2 and DHS2 is the integration between these two databases. And we know that the source of DHIS2 is CTC2 data. And currently, even those facilities with electronic database do have a summary. They print summaries and get it to the councils. So we want to actually integrate between CTC2 and DHIS2, and data should flow directly. And this will be done through a mechanism called S-Information Mediator, and this is a platform. And we expect this to start in January 2023. As I said, paper-based clinics will continue the old fashion, but we are also planning to give tablets in those facilities which are lower, which are not having electronic CTC2 database, so that they will have the CTC2 data captured in these tablets and go straight into DHIS2. So with time, we expect that all facilities, all HIV clinics will have CTC2 data linked into DHIS2. But to start with, those with electronic will start in January next year. And this is the platform I spoke about. You agree with me, we have a number of electronic medical records, including GoToMI's, Afya Care, and all this will, and CTC2 will also come in that layer. So they will get the information to the DHIS2 straight from the facilities. So there won't be any need for our healthcare workers to print quarterly reports and get it to the DACs and enter into the DHIS2. So by doing so, we expect that our data will have an improvement. Another update, I think I told you about the biometric registration, which is one of the extensions within CTC2. Another one is unified community system. You will agree with me, we have a number of interventions at the community levels, including HIV self-tests, VMMC, which are being done at the community level. So we want to have this captured electronically as well. So we have started this using tablets, and a number of modules have also been there. One of them is RCH, including PMTCT. So we have also included HIV self-tests, PrEP, condom programming, and the like. And they will be under a unified community system, and they will get the information again direct into DHIS2. So a bit on the unified community system, we have these applications, apps. We have Waja, which is huduma za majumbani. We also have an application on health facility Kituoni, but we will also have a dashboard where some summary will be also shown within the unified community system. So I think this will be more of a repetition of what my colleagues have said, but there's no harm in repeating. We have a problem on case identification, as Mohammed and the other colleague has said, and this is not across all ages, but it's especially in children and young people. And there are a number of interventions we are planning as program to take care of case identification. But the other thing is virus suppression. Again, we are struggling with children and young people. These are doing fine. Reducing new infections, I think Mohammed also showed us. We want to reach somewhere here by 2025, but you'll see where we are now. So we do have a lot of things to do for us to reduce the new infection rate, for us to achieve HIV epidemic control. And On the right there, the different strategies to take us to reducing new infection. We are also struggling in reducing mortality, as Mohammed say. For this, we are doing a bit nicely, but we need to close the gap by the end of 2025. So this marks the end of my presentation, and thank you very much, and welcome for further discussion on that. Asante sana.
Asante sana Dr. Wena. Naomba tumpigie tena makofi tafadhali. Asante sana, na wawasilishi wote sasa wamekuwa wakizingatia muda vizuri. Tunajiandaa sasa, baadaye tutatoa summary kwa ajili ya discussion wakati tunafanya discussions ya yale ambayo ameyapresent, lakini sasa hivi tutapata presentation inayohusu, tutapata overview ya PMTCT program ambayo itawasilishwa na Dr. Mkome Nyamhagata kutoka PMTCT program. Karibu Dr. Mkome.
Asubuhi ni mchana sasa. Good afternoon. Yeah, my name is Mkome Nyamhagata. I'm working with the PMTC program at the Ministry of Health. Yeah, I'll be sharing with you on some PMTC program updates. My presentation will take you through a little bit of a background and PMTC interventions, program performance, successes and challenges, way forward, and take home message. Currently, we have now passed 22 years since we started piloting the PMTC services in Tanzania under the platform of reproductive, maternal, newborn, and child health services. In 2012, we adopted the global recommendations on virtual elimination of mother-to-child transmission of HIV and developed our own country plan that took us from 2012 to 2015. This is the EMTC Strategic Plan 1. This strategic plan had a target to reduce the MTCT rate from 26% in 2011 to 4% in 2015. But unfortunately, we could not reach that target. However, with much effort, actually, the final MTCT rate was 7.6% in 2015. And currently, we are talking about 10.9%, close to 11% rate for HIV. In summary, our response has evolved through various phases, and the first phase actually was a pilot response. This was between 2000 and 2004. And after 2004, we started scaling up the PMTC services into many more facilities and regions. In 2008, we developed a scale-up plan which enabled us to reach at least 56% of the facilities with the PMTC services. And after the launch of the global plan for EMTCT in 2011 in New York, we adopted that global plan for elimination, as I said earlier. And right now, we are still in our elimination phase. The elimination phase can be actually divided into 3 phases. The first phase was between 2012 and 2015, where we had a virtual elimination of HIV, vertical transmission of HIV alone. But from 2016 to 2020, we adopted dual elimination of HIV and syphilis as a way to spearhead the agenda for integration. So syphilis was also taken on board in our second strategic plan. But currently, we are now spearheading the agenda for triple elimination. We have taken on board also hepatitis B viral infection. Therefore, the agenda now is triple elimination. Our essential triple elimination interventions include HIV testing at ANC clinics, syphilis testing, also hepatitis B screening among pregnant women attending ANC clinics. And for those who will be found infected, for either of the three assailants, will be provided with efficacious treatment to reduce the risk of infection to their exposed infants, but also for their own health. Other interventions include counseling for women and their partners to reduce transmission risk, but also to provide the appropriately attended safe delivery care for those women who will go into delivery. And other interventions include follow-up of exposed infants, including provision of hepatitis B vaccine birth dose. This is actually intended to begin next year. So we are now in a planning phase to ensure that the timely birth dose vaccine for hepatitis B prevention in infants is provided. And optimal infant feeding is the other interventions within the program, and the lifelong treatment and care for mothers infected with HIV and their families, including also care for and treatment for hepatitis B viral infected women who will be having signs and symptoms of liver cirrhosis. I will take you through in a short summary of the program performance. The facility coverage has increased over the past 4 years from 92% of RSH facilities to about 80% of RSH facilities providing also PMTC services. But the testing uptake HIV has sustainably been high at around 98% for the past 3 years. And but however, we still have a gap in terms of syphilis screening prenatally. Prenatal screening of syphilis went up to around 75% in 2019, and this was due to introduction of the dual HIV syphilis test kits. But then it has gone down between 2020 and 2021, and I think the main issue here was stock out of dual test kits amid COVID-19, which brought about some procurement and logistic issues. However, among those women who are tested for HIV, we have seen almost a stagnant or slightly decreasing trend in terms of HIV positivity. Overall, HIV positivity, including those who are non-HIV positive at first ANC visit, has been between 3.4 and 3.1 between 2018 and 2021. So it's slightly decreased to 3.1 in 2021. But the new positives, the positivity for those who are newly tested, has slightly decreased from 1.5% in 2018 to 1.1% in 2021. ART uptake has been high. The overall ART coverage has been above 95% between 2018 and 2020, but we saw a slight decrease in 2021, where only 90% of women who were PLHIV, who were living with HIV at antenatal care clinics received the ART. But if you disaggregate them, between those who are known positive and the newly tested, we see a huge gap of about 20% of missed opportunities for ART among those who are newly diagnosed. This actually was the main attributed to high transmission rate last year. This stacked bar try to show the gap among pregnant women within the population as elaborated from the estimates. The majority of women coming to antenatal care clinics knowing their status and are on ART before becoming pregnant. For last year, around 51,000 women were on ART before becoming pregnant. This is more than 50% of all pregnant women living with HIV identified last year. But there were around 2,700 women who were newly diagnosed at ANC clinic and started ART during pregnancy. And among them, between around 1,500 dropped off care. They were not retained. But there were also 2,200 who started ART late in pregnancy. And worse enough, we had a gap of about 17,400 women who did not receive ART at all. They were HIV infected within the population, but they never received the ART. And this contributed to about 38% of the new infections among children. And we had about 3,200 women who were infected during pregnancy. And also we have incident infections during breastfeeding. All these contributed to the high transmission rate of 11% that I mentioned earlier. HIV exposed infant enrollment and testing. We see the enrollment has been decreasing between 2018 and 2020, but went up to 83% in 2021. However, the infant testing also started increasing between 2019 and 2021. And actually this was much attributed by the adoption of point-of-care technologies for HIV testing. We had the regional differences in terms of testing, EID testing coverage within 2 months of age. Kagera, Iringa, and Dar es Salaam did very much well. They surpassed the 95% target of infant testing. Positivity among the tested infants has been low. It went down from 2.6%, the overall positivity, regardless of age, went down from 2.6% in 2018 to about 2% in 2020, but it slightly went up to 2.4% in 2021. But among among infants tested within 2 months of age, the positivity was 1.7% in 2021. But we see much of the exposed infant identification was at birth. At birth, most of the tests that were conducted were positive. It might be because we are testing the high-risk exposed infants only. That's why we see the high positivity rate at birth of 60%. That might be the reason. But this was the picture for 2021, where 6% of the exposed infants who were tested at birth were actually HIV positive, compared to 0.6% positivity within 2 months of age. But also we see many more positive exposed infants occurring between, for the tests conducted between 9 and 12 months, where 4% of the tests conducted at that age time point actually were HIV positive. And 12 weeks after stopping breastfeeding, 3% were positive, and at the confirmatory, 3.1% were positive. So this underscores the importance of including many more testing time points to identify new HIV infections among infants. We have managed to conduct maternal retesting mentorships countrywide to enhance skills in conducting maternal retesting, and also, with the aim of identification of incident maternal infections and taking care of them to reduce MTST risk. We have also managed to review the MNE tools, though we have not printed them yet, and we have not distributed them yet, but we have managed to review them so as to incorporate the issues of maternal retesting and triple elimination, especially the hepatitis B infection prevention interventions. We managed to optimize 130 gene expert platforms for EID at point of care, and we also managed to develop the PMTST case-based management system in collaboration with paper partners and the NACP. We still have challenges on early booking, so most of women come to ANC clinics late in pregnancy. We also still have challenges on uptake of maternal testing. Way forward, we all gene expert platforms available in country with the point of care EID testing. So we want to optimize them all. 340. We have 340 gene expert platforms within facilities in the country, and we wish to optimize them all with the EID testing. And also we are planning, we are planning this to be achieved by 2023. We also plan to scale up the PMTST case-based management system. So this is actually a client-centered monitoring system that will help us reduce a lot of inequities in terms of patient care. And also we want to adopt the triple testing strategy at RSH clinics and introduce the timely birth dose and the hepatitis B immunoglobulin for prevention of congenital hepatitis B infections, and forecasting ARV prophylaxis for prevention of congenital hepatitis B infections. And also we wish to conduct frequent data quality assessments and strengthen death testing using threshold blood at the point of care platforms to increase coverage of EID. The take-home message that despite that we have good progress in maternal HIV testing during pregnancy, the coverage of maternal testing for identification of incident HIV infections is quite low, and the ART coverage among the low ART coverage among newly infected women is a high risk of infection to HIV exposed infants. Optimization of point of care technologies is necessary to scale up the EID testing. We acknowledge the support from our partners, especially the UN family. The Global Fund, as part of the UN family, has been doing wonders, and also the US government, RHMTs, CHMTs, PEP5Ps, and CSO.
Let's give him a better one. Dr. Mkome, this has been very informative. We have just been informed that UNAIDS has provided us a summary They called it Know Your Epidemic. It's a summary of Tanzania HIV and AIDS epidemic and response data and information that is available. They have printed several copies and will be distributing to us all. Just make sure you get your copy. It's a very informative summary. I would like now to invite my presenters to the high table. We'll remove the board to take your comments. We have 30 minutes according to the program for both giving your comments and inputs as well as getting the feedback from the presenters. So please try and use at least a minute, go direct to the question and address issues that were in the presentation. And if you have longer comments, please write them and we will be happy to summarize them with the Secretariat and share with the presenters. So use this time as economic as possible. Please karibu to the stage, all the 4 presenters. Karibuni. Guys, how is your energy levels? 50? 60? CDC, how much? 97, fantastic. Okay. We will, I wanted to give a brief summary, but given the pressure of time, we'll go directly to your questions and issues, and then we will try and talk them through as we continue. So, nani ataanza? I know some have already submitted in writing. Nakumbusha tu, we had the first presentation from Dr. Mohamed Toure from UNAIDS. Ametukumbusha masuala mbalimbali muhimu sana ambayo cha kwanza ni kwamba we are doing better but not exactly on track. We are on track but not exactly. We need to recalibrate. We need to readjust how we focus our response to be able to be real on track in reaching the goal, the 2030 ambition of eliminating HIV and AIDS as a public health concern. Any hand? I know they're fairly difficult. Oh, let's start with this one.
Thank you very much, the presenters, for nice presentations that we have made. Dr. Mkombe provided us.
Can you identify yourself first?
Thank you. My name is Jimson Mgaya from HGFMRI, Southern Highland Program. So I would like to thank the presenters for good presentations, but my question or comment goes to Dr. Mkombe, who presented on the data of where we stand now on PMTC program. And during his presentation on EID, actually from all the tests that have been being done, the positivity has never gone beyond 4%. But during the introduction, then it said currently the MCT rate is at around 11%, which I fail to understand. Why does it do we have that MTCT rate, while during the infant test, the early infant diagnosis test, we have never gone beyond 4%. And in connection to that, would you be able to give us the breakdown by regions on how this burden is, the MTCT rate? Thank you.
Asante sana. We have a hand at the further end there. Papo.
Hello. Yes. My name is Michael Johnson Mahande, the professor of epidemiology and biostatistics from MDH, and the supervisor of the two presenters, Dr. Wainama Okola and Dr. Farida, the graduate from KCMUCO. Yeah, maybe my question to Dr. Wena. You have demonstrated the HIV DRA across different regimens, even the one which we trust has shown some evidence of resistance. What do you, where do you see the fate towards the prevention of the HIV? Thank you so much.
Asante. So my name is Raymond Bandio and I'm from PSI Tanzania. So my question goes to Dr. Mkome. So I just want to understand in terms of the PMCT program in the country. So I think you presented 2015 we are around 7.6 prevention mother to child EMTC rate, but now we are around 10.9, which is almost 11%. And actually presented a very good interventions, and with a 22 years age of PMTC program, I would wish to hear from you. Are we doing better now compared to 2015? And if not, what needed to be done to lower the EMTCT rate to a single digit? Thank you.
Asante sana kwa nafasi hii. Furahi kwamba kumekuwa na program hii nzuri na ni mimi mara kwanza. Jina langu in fact naitwa Mbaraka Mchome, natokea Morogoro na ni mwakilishi tu wa mamlaka ya maji kule. Nimepata nafasi ya kuja hapa. Nashukuru sana. Vipimo vilivyopata ni hepatitis B, vipimo vya hepatitis B na C, na nashukuru Mungu sija kuwa affected. Lakini nimepata nafasi hii pia kupata fursa ya kuuliza kupitia hicho. Ni kitu ambacho kimenishtua kwa sababu baada ya maelezo mengi na kuhoji pale nimesikia ni ugonjwa wa hatari, na baada ya kuona kuna fursa ya kutaka kujua zaidi ningefurahishwa kama wakilishi wa mwisho aliyekuwa anazungumzia juu ya swala la hii hepatitis B na mengine pia angekutusaidia kwa faida ya wengine, hasa mimi, kwamba sijawa affected. Inachukua muda gani kama nikatembea kurudi nyumbani nikawa affected? Of course njia ya kuwa affected ni nyingi, na kama nikiwa affected nikagundua, ni muda gani ichukue ili kuweza kujitibu ili nisiwe nimeumia? Labda nimeeleweka. Asante sana.
Thank you. My name is Frederick from EGPAF, USAID Afyangu North. Mine goes to Mohammed, and I would like to understand a little bit of the methodological aspect on estimating the burden around clients of sex workers, and how is that different from the context of the index patient? How do you tease that out? Thank you.
Can he come again with the question? Now, if he can re-ask the question. Yes, the EGPAF colleague.
No, I was just asking in terms of estimating that we don't overestimate or underestimate the burden, because we have identified clients of contacts of sex workers as a special group with a high burden. So, but we already know that we are also estimating the burden among the contacts of the index client. So I wanted to know methodologically, how is that different, and to what extent do you use that estimating or underestimating the burden in that subpopulation?
Thank you very much. I would like also to thank the presenters for their very nice presentations. My question is just for clarity, and it goes to Dr. Farida. When she was presenting on PMTST coverage for Lindi region, she said for PMTST, there are 44% of health facilities are providing PMTST services, and 49% HIV can treatment services. But I would just like to know, among the 49% of can treatment, they're also among for PMTCT. Maybe I just want to know.
We'll take three more questions from here, and we have two hands from the left.
Asante sana. Emmanuel Bahemana from HJF February, Southern Highland. Swali langu linakwenda kwa Dr. Wena. Nimekuwa a bit concerned na findings za HDR. Ukizungumzia prevalence ya 5.8, I think kwa IIs, and or the other way around, and 8% they a bit concerned. Study ambayo sisi tumefanya recently kwa pediatrics 1 to 19 years, hatujaangalia la integrase inhibitor, tunaangalia PIs, na ukirifaa to some findings literatures, percent bado iko chini sana. So finding ya I think 5.8 kidogo ni alarming. Can Dr. Wena comment about that? Asante.
Thank you. My name is Kivenule from Takets. My question goes to Dr. Muhammad. I just want to know the extent of a new infection among youth globally. What is the situation?
Thank you. My name is Agnes Kirato from THPS. My question goes to Dr. Komi. You mentioned that the positivity rate for children at birth was at 6.1%. That's quite alarming. And I would just want to know what are the strategies in place to capture these women that are dropping out. We had around 1,500 women that have dropped out from care. And what are the strategies in place from the MTCT department? Thank you.
Thank you. I think this will be the last question at the moment for this session. We'll have more opportunities in the coming sessions to be able to discuss that. I will now turn to my panelists here, my colleagues, to respond on the questions. We will use the same sequence as we used during presentation so that we allow time for others to prepare. Dr. Mohammed, you're going to be the first one to respond to any questions that are coming in. And please, there are questions that have come in that are outside the presentations that have been made here. And it will take time for a presenter to be able to access information that has been requested. Please follow up individually if you need more clarification on things that were not done here in the presentation, because it is difficult to be able to carry all the data and information with yourself on the hand.
Yeah, thank you so much for the question. The process, basically, every year, through the Global AIDS monitoring process, there is a lengthy set of indicators that countries have to provide data on, okay? And these data sets are collected at the global level by UNAIDS and are being analyzed. These data sets are not only restricted to program level data, but for clients of sex workers, as we may be aware, some of us here, most of that data is really collected through surveys. So there is a survey workbook that UNAIDS prepares based on the set of surveys that have been conducted globally on clients of sex workers. And it's that data set analyzed at the global level. But again, we do have another tool called Spectrum. Dr. Mukume highlighted that in his presentation. For generalized epidemic, like we have our own spectrum set of indicators in the model. But for concentrated epidemics, the configuration of their model is different, okay? And some of these data sets can be derived from modeling from concentrated epidemic models, such as Spectrum, but configured for concentrated epidemic. But to answer your question briefly, that data, most of that data actually came from source. Through modeling can be used to the survey data sets. But that is basically where the data is coming from. And those survey data sets are coming from so many countries across the globe, just as programs are also provided. And those are analyzed at UNAIDS. And that is how they came up with those figures. Thank you. I hope I answered your question.
Facilities that offers HIV/AIDS services were not specifically like to say maybe 130 health facilities provides DC only. No. It means that one of the facility can provide HIV testing services, care and treatment, and PMTCT. So the 44% of the health facilities that provides PMTCT services could be also providing other services. I think I answered your question.
Thank you. I would like to respond to what Professor Mahande raised on DTG resistance. Just a note, yes, it's surprising to see such a high level of resistance due to DTG, which has been with us for a short time. And we all know that DTG is a very high genetic barrier, and we expect to have few mutations when you use DTG. But possible reasons for this could be probably we have other people who are using these regimens before I introduced in the country. That's one of the possibilities. And no wonder we are having people here using our third line defense while we haven't yet started using them in the country. So in that process, you may have mutations because this drug has been in the country for such a long time, and mutations are geared by drug pressure. The other thing, as I showed in the presentation, we have high mutations with the NNRTIs and NRTIs. And for example, for those who are on TLD, the backbone is NRTI. So some patients may be on monotherapy because NRTIs have failed. So, and resistance may emerge from that source of scenario. But the other thing is these drugs have been tested at least up to phase 3 clinical trial outside Tanzania. So that's why it's very important to do phase 4 surveillance when these drugs are coming into our countries. And to do that, we are thinking of doing drug resistant surveillance in some of these facilities, the sentinel surveillance, so we can capture mutations which are coming rather than waiting for surveys. So possibly those are the sources of mutation, but with regards to the threat of HIV treatment, yes, if you have mutation, the drugs won't do, but we have mechanisms to detect if we are failing. So I don't think the clinical criteria for failing drugs, which gives us a chance to do genotyping, have failed so much. So we will detect the treatment failure using clinical criteria as usual. So there's no problem there. Thank you.
I'm going to respond to about 3 questions that were directed to PMPCT presentation. The first question was from Jameson on EID positivity and the transmission rate. In accordance to his question, the positivity looks low, about 2.4%, but the EMTC rate is 11%. He wants to know why the EMTC rate is such high. Yeah, the EMTC rate, as I said earlier, is calculated from the spectrum model. This is a mathematical model which triangulates program data, population data, and also surveys and surveillance data. So from this model, what we get as an output is actually considered as a population output. But the positivity rate I was talking about there is from the program data only for those clients who come to the facilities. It doesn't include those who do not come to the facilities. So that's why you see the missed opportunities in client care contribute much to the infections and takes the EMTC rate to 11% as compared to the positivity rate of 2.4%. So this is the difference between the two. And he had another question, can we have a regional breakdown of the EMTC rate? Actually, I can say yes, because when we develop the national estimates, regional estimates, where all the regions come, they develop their own targets and also estimates. So we can have the regional breakdown of the estimates on EMTC can be accessed also. Bandio asked that 7.6% was the EMTC rate in 2015. And now we are talking about 10.9%, close to 11%. Are we doing better?